So with oncology, my main focus here, we're going to talk a little bit about the most common cancers and go over some of the basic features. And the goal here is not to have you well versed in the nuances of staging a cancer and picking chemotherapy drugs. It's more about understanding basic principles of risk factors, screening, clinical presentation, the workup, and a basic understanding of management from an overview approach. So we're going to talk about a review of some common cancers, and that'll probably be the bulk of our hour. And then in closing, we'll hit on a few complications related to cancers themselves. And then we'll talk about cancer therapies and complications of cancer therapies as well, including some key drug side effects that we already started talking about last hour, tumor lysis syndrome and febrile neutropenia. So cancer incidence, you can't really talk about cancer without understanding a little bit about what are the most common players. So it's breast in females and prostate in males. And then for both males and females, lung and colorectal are 2 and 3 respectively. For cancer mortality, lung is number 1 for both. And then as you see, breast, colorectal for women and prostate, colorectal for men. And that hasn't really changed in terms of the order in a while now. So we talked about what you should know for each major cancer type, and if you know this, you know a lot. And so if you're when you're preparing for your boards and you're doing your last run through on oncology, basically what you would do is pick a cancer and then look at this checklist and be like, am I good with everything on this checklist? And if you are, then you're good to go. So let's work on that. So breast cancer. Breast cancer gets a little bit more attention because breast cancer is everywhere, right? It's everywhere in your clinic and it's everywhere on the boards. This is the most common cancer, and as we said, second leading cause of cancer death in women. You should know what the risk factors are for breast cancer, including a personal history of breast cancer or benign breast disease, like LCIS or DCIS. Anything that increases a woman's endogenous estrogen exposure can increase risk. So early menarche, late menopause, nulliparity, increasing age, family history is a huge factor, inherited genetic mutations, which we'll talk about in just a second, and then that moderate to heavy, it should be moderate to heavy alcohol intake is also a risk factor. But what about these genetic mutations? This is getting a lot of attention in the literature and in the press. So the BRCA1 and 2 genes lead to hereditary breast and ovarian cancer syndrome and accounts for up to half of all inherited cases of breast cancer. So you should understand the BRCA1 on chromosome 17. And what's most striking about the BRCA genes is just how high their penetrance is. So with BRCA1, a woman's lifetime risk of developing breast cancer is as high as 85%. Risk of developing ovarian cancer is 40%. And there are also increases in the risk of colon and prostate cancer, though to a much lesser extent. With BRCA2, there's a similar risk of breast cancer, slightly less risk of ovarian cancer, about 20%. This compares to about a 1% risk of ovarian cancer for the general population, just as an FYI, and then some increased risk of other cancers. So BRCA1, BRCA2, hereditary breast and ovarian cancers. And in a couple of minutes, I'll talk to you about who you should think about screening for these mutations. Screening is a high-yield topic for a lot of cancers. Screening for breast cancer, it has undergone an evolution. There's been some areas of controversy. We're going to make it very simple today. There's different ways that you can screen for breast cancer. The key ones to focus on are mammography and breast MRI. The latest guidelines from American Cancer Society and U.S. Preventative Task Force do have some subtle areas of disagreement. And so whenever you have this, and you see this in different oncology subspecialties where there's different societies with different recommendations, you're never going to be tested on the nuances and the differences. Focus on where the guidelines agree with each other. So if we do that, what you should recall is that screening mammography is appropriate every 1 to 2 years for women ages 50 to 74. It has less utility, but still can be used in ages 40 to 50 and above age 74. And breast self-exam and clinical breast exams, at least from an evidence-based perspective, are not useful in preventing breast cancer. That doesn't mean I'm saying you shouldn't do them, but the evidence doesn't support it based on the latest guidelines. Recall that there are certain scenarios where your mammogram might not be quite as accurate or sensitive, and that includes younger premenopausal women who have dense breast tissue. There may be some nuances related to timing in the menstrual cycle, and women that are on hormonal therapy may have decreased sensitivity of their mammogram. Breast MRI is kind of the new kid on the block. This has really become used more in the past decade or so. Very high sensitivity, but limited specificity. So it picks up everything. So lots of false positives, and that's why we don't indiscriminately have every woman do this. But you should use it in high-risk women, such as the ones listed here, including BRCA 1 or 2 positive, or women that for other reasons might have a higher than average risk of developing breast cancer, and thus it's justified to do a test that is going to carry risk of these false positives. And that includes prior radiation to the chest. So tying together our Hodgkin's survivor that we talked about, who maybe at age 22 had radiation to her chest for her Hodgkin's disease, when she comes to see you at age 25 or 30, you're going to want to think about breast MRI because of her risk of getting breast cancer. Presentation for breast cancer. There used to be a lot of different things we talk about. Honestly, most of the time now it's found on a mammogram. Asymptomatic, routine screening mammogram. But that's not as exciting to write questions about, so you should know some of the outliers. So there could be a painless breast mass that the patient notices. If you have a woman who presents with eczema, but only on one side, eczema of the nipple, only on one side, think of Paget's disease of the breast. Nipple discharge, nipple retraction or dimpling of the skin, and then you can have inflammatory breast cancer where you have almost, it looks like mastitis, but in a non-lactating woman with a very enlarged erythematous, tender and hard breast, and this denotes a very aggressive type of breast cancer. Occasionally, you might see a case where you have an enlarged axillary lymph node, but no breast mass. Always treat that as breast cancer, even though you can't find the breast mass, because statistically that's what it's most likely to be. So how do you work this up then? So let's say a woman comes in your clinic and she palpates a 2-centimeter nodule in her own breast, and she comes to you. What do? You always image first. The first step is never biopsy or cut it out or anything. You always image first. You image with a mammogram and an ultrasound. The mammogram is to assess what the risk profile of it is. The ultrasound is to determine if it's solid or cystic. After you've imaged it appropriately, the next step is biopsy, not surgery. Don't remove it, you biopsy it with a needle, either an FNA or a core needle biopsy, depending on whether it's solid or cystic. And then on your biopsy, if you've determined that it is breast cancer, then your next step is you check the receptors, ER, PR, HER2, we'll talk about that in a sec, and then you stage it and then you treat it. Let's say that a woman presents to you and you palpate a 2-centimeter mass in her left breast, and so you go through step 1 and you image it, and it's normal. Mammogram's normal, ultrasound's normal. And the question will ask you, should she come back in 3 months, come back in 6 months? No, you biopsy that. Never let that go, even if you can't find it on imaging, and that's cancer until proven otherwise. So that brings us to our first case. A 53-year-old postmenopausal woman finds a breast lump. Ultrasound and mammography, because you appropriately remember what to do first, confirm a suspicious 3-centimeter mass. You then do a core needle biopsy, and it's positive for infiltrating ductal carcinoma. A lumpectomy and axillary node dissection are done. The cancer is 3 centimeters with 2 positive axillary lymph nodes. You test receptors, and the ER/PR receptors are negative, as is the HER2. Okay. Which of the following should you recommend? Repeat surgery with conversion to mastectomy, radiation plus tamoxifen, chemotherapy followed by radiation, close follow-up with an exam every month, or local radiation therapy alone? What do you guys think? Okay, pretty good. So 57% of you correctly identified the right answer here, which is chemotherapy followed by radiation. So again, the nuances of what type of chemo and all of that, you don't have to know, but this is fair game to understand what types of therapies are appropriate, and I'm going to help make this very easy for the other 43% of you. So how do we figure this out? So breast cancer, you assess prognosis based on the size of the tumor, the lymph node status, the presence of metastasis, and then the ER, PR, and the HER2 status. We use multi-gene assays like Oncotype in certain cases, and then we have a staging system that you see here, the AJCC staging system. But basically, what you need to know to be able to answer these types of questions is that there are two main goals to treating breast cancer, or two main sort of concepts. One is local control, and that means remove the tumor and decrease the risk of a recurrence in the breast axillary area. So that is accomplished with surgery, which can be either a mastectomy or a lumpectomy plus radiation, okay? Plus sampling of the lymph nodes in the axilla, which used to be a full dissection. Now we do sentinel lymph node biopsies where we just take out one or two and by using a blue dye, and if those are negative, we don't have to remove the rest. That's local control. Either mastectomy or a lumpectomy plus radiation, and then sampling the axillary lymph node. So that's the first goal. But the second goal is systemic control. And what this means is treating and getting rid of any possible microscopic disease that has escaped from the breast. Microscopic micrometastases, as we call them. And this is done through the use of drugs, medications. And there's a few different types: endocrine therapy, estrogen blockade, chemotherapy, and then biologic therapy like trastuzumab, which is a HER2 monoclonal antibody, only for those cancers that are HER2 positive. So let's talk a little bit about these different systemic therapies. So endocrine therapy. All breast cancers that are ER or PR positive should get anti-hormonal therapy. Easy, right? So you won't ever miss that, right? So this case that we had, the ER, PR were negative. So the right choice is never going to be anything that has tamoxifen or like anything like that. You only use these when they're ER, PR positive. Which drugs do you use? The details are on the slide, but to simplify it, if they're postmenopausal, aromatase inhibitors are the best drugs. Letrozole, anastrozole. What should you recall about aromatase inhibitors? The main side effect I want you to know is osteoporosis. So you must monitor a bone density every couple of years when they're on aromatase inhibitors. So that's for postmenopausal women with ER, PR positive breast cancer. If they're premenopausal, tamoxifen is your preferred drug. Tamoxifen, what I want you to know about that drug, there's very small risks of uterine cancer, so they need to see GYN every year, and there's a small risk of DVT-PE, so you have to take prophylaxis in high-risk situations. So younger women, tamoxifen; older women, aromatase inhibitor. Everybody who's ER, PR positive gets one of them. Okay, how about chemotherapy? So we don't give chemo to everyone. We only save chemo for the higher risk ones, where it's worth the toxicity, right? So if there's positive lymph nodes, if it's a large tumor, or if they have a high recurrence score on this genomic assay that I mentioned. And then the HER2 antibody, the trastuzumab, you only give that if they tell you that the cancer is HER2 positive. And if the HER2 is not positive, you never give this. So wrapping it up, in breast cancer, local control we talked about, I won't repeat that again. Systemic control, if the tumor is ER, PR positive, you give endocrine therapy, tamoxifen for younger, aromatase inhibitor for older. If the tumor is high risk, then you also give chemotherapy. So it's an addition to. And that's if they're node positive or if they have a high risk recurrence score. And then if they're HER2 positive, and only if they're HER2 positive, do you give trastuzumab, right? So then if we are armed with that knowledge, and now we go back and we look at this question, now let's look at it. So a breast lump, 3 centimeter mass, ductal carcinoma, a lumpectomy is done. So then you're like, aha, I know she's going to need radiation afterwards, right? And axillary node dissection is done. The cancer is 3 centimeters and it has 2 positive lymph nodes. So I know she's going to need chemo, right? ER, PR receptors are negative, so she doesn't need hormonal. And HER2 is negative, so she doesn't need trastuzumab, right? So once you think through the question like that, the answer just jumps out of the page at you, or I hope it does. And so that's breast cancer 101. If you know that, you should know enough in terms of dealing with management of breast cancer. Just a word about following breast cancer survivors, because there's a lot of breast cancer survivors, and thankfully there's going to be many, many more. You follow these women with H&Ps. What you don't do is all of this stuff routinely. So if you have an asymptomatic breast cancer survivor, you don't do lab work and bone scans and ultrasounds and tumor markers and PET scans. It's not recommended by national guidelines unless they have a directed sign or symptom. There's a few reminders in here about get your pelvic exams on tamoxifen, get your bone densities if you're on the aromatase inhibitors, and then some criteria here for when you should think about genetic counseling or testing, like I promised you. And that's for people who get breast cancer at a young age, people who have a lot of cancers in their family, or people that have had multiple episodes of breast cancer. You want to think about the BRCA mutation testing, and usually that's done by a referral to a genetic counselor. Okay, great. So now let's just kind of hit on and kind of rapid fire some key points on a few other cancers. Cervical cancer, mortality has dropped almost 70% since the introduction of effective screening with the pap smear. There is a bimodal distribution. And what I want you to know here is HPV is the primary risk factor. More than 90% of cervical cancers are associated with HPV, specifically types 16 and 18. And most of the other risk factors for cervical cancer are related to the risk of acquiring HPV. And that includes multiple sexual partners, low socioeconomic status, presence of HIV. Recall that there is an HPV vaccine, and universal vaccination has had a major health impact. This targets the oncogenic strains, which are type 16 and 18. And it actually is the first wide-scale vaccine that's effective in preventing cancer, right? So it's 97 to 100% effective in preventing cervical cancer in females, and it may prevent anal cancers in females and males. It is now recommended for females and males, and the age has been broadened as of 5 months ago to where it's now ages 9 up to 45 are recommended for the HPV vaccination, and it's females and males. So how about screening for cervical cancer? It's pretty straightforward now. It used to be all over the place, different opinions. It's straightforward. You start screening, and you use the pap smear, right? You start screening at age 21 for all women. Doesn't matter age at first, sexual intercourse, all that stuff that used to matter doesn't matter anymore. Start at 21. And for their 20s, you screen every 3 years with pap smear alone. Every 3 years. Once they hit 30, you have options. Either you can continue to do your pap smear every 3 years, or you can co-test with pap and HPV DNA testing, and then it's every 5 years. So this is a big change. And so some women have come to me and grumbled about how their OBGYN doesn't want to see them as often, and they think it might be an insurance. And no, it's the change in the guidelines. You can do every 5 years if you co-test with pap smear, cytology, and HPV. And you stop at age 65, as long as they've met these criteria here. So when their age is 21 to 30, pap is your only option. But after 30, you can co-test with the HPV. And it doesn't matter whether or not they've gotten the vaccine. Oh, so doc, I got the HPV vaccine, so I don't have to follow those. No. Yes, you do. It doesn't matter. Irrespective of that, you get screened, and this is how you get screened. So if you've mastered that concept, then what do you do when you screen your patient and it's abnormal? How do we work up an abnormal pap? So a 26-year-old woman presents with an abnormal pap smear showing low-grade squamous intraepithelial lesion, no inflammation. She's HIV negative, and a pap 2 years ago was negative. Which of the following is the most appropriate next step? Return in 4 to 6 months for a repeat pap, cryo or laser therapy, hysterectomy, conization, or colposcopy. What do you guys think? Okay, very good. So 2/3 of you correctly recognized colposcopy with biopsy as the next best choice. And again, as you might be realizing, I'm a big believer in keeping things simple so you don't get lost in details. Most of the time, if they give you an abnormal pap, the correct answer is going to be colposcopy. And that includes if you have low-grade SIL or squamous intraepithelial neoplasia, high-grade SIL, atypical glandular cells, high-risk HPV testing with a normal pap. If you have a visible cervical lesion and your pap is normal, colposcopy. The only exception where you could escape or get away from doing colposcopy is if you have ascus or atypical squamous cells of undetermined significance. And even then, it's not wrong to go to colposcopy, but you have the option of doing HPV testing and then risk stratifying based on that. But if you are stuck and you don't remember, just pick colposcopy, and most of the time you're going to be right as the workup for an abnormal pap. And then this is just a few words on cervical cancer itself, which I don't think it's good for you to have a familiarity with, but I don't think it's quite as high yield. But basically, early stage is treated with surgery, more advanced stages with chemoradiation or chemotherapy. But again, I want to focus more on how these cancers present, what their risk factors are. So with that, here's a 60-year-old woman who presents with increasing abdominal girth and dyspnea. On exam, she has ascites, and a pelvic ultrasound shows a right-sided adnexal mass. Which of the following is not correct? Treatment should include hysterectomy, oophorectomy, and omentectomy, gross tumor resection, and biopsies. There is an increased risk of this cancer with BRCA. CA-125 should be ordered. There is an higher than 85% likelihood that the mass is a germ cell tumor, and most ovarian tumors are diagnosed with advanced stage disease. Which is not correct? Very good. So 2/3 of you correctly recognize that in older women with an ovarian mass, it's most likely to be an epithelial carcinoma of the ovary, like an adenocarcinoma of the ovary. Younger women who present with ovarian masses are more likely to have germ cell tumors, and that's a minority. Most of the time, ovarian cancer is in older women, and it's epithelial carcinomas. If you have a young woman with an ovarian mass, maybe has some virilization symptoms like hirsutism, that's where you might see a germ cell type of tumor. So that's good. All the rest of these statements are correct. We talked about how there's up to a 40% risk of ovarian cancer with BRCA, so that's good. You guys didn't really pick B. Treatment should include aggressive surgical debulking, and although CA-125 is not routinely ordered for screening, once you think you're diagnosing a cancer of the ovary, it is appropriate to order that marker. So we summarize here, most of the cancers are epithelial in postmenopausal women. Think about germ cell in a minority of cases in younger women. The risk factors, and again, don't memorize. If you just understand, it'll stay in your mind. The risk factor, the higher number of ovulatory cycles a woman has in her lifetime, the higher her risk is of ovarian cancer. And inversely, the lower number of ovulatory cycles, the less risk. So anything that decreases a woman's number of ovulatory cycles will lower her risk, such as multiparity, if you look on the bottom here, early menopause, breastfeeding, and oral contraceptive use. We talked about the genetic factors. There's also Lynch syndrome, which is we mostly think of with non-polyposis colon cancer, but there's also a 12% risk of ovarian cancer here. There is no routine screening for the average risk population, but if you have high-risk patients such as BRCA women, you can consider CA-125 and transvaginal ultrasound, but only for high risk. The typical presentation is just like our woman in our case: abdominal bloating, ascites, pelvic pain, and then you work up as we described with imaging and markers. And the primary treatment is surgery. Even in advanced disease, the primary treatment is surgical debulking. Get rid of as much of the tumor as you can, and then give chemotherapy afterwards. And like with all cancers, prognosis depends heavily on the stage. So that's ovarian cancer. Remember that as part of the BRCA. Remember that if you have an adnexal mass in an older woman, it's probably epithelial. In your next step when you're working it up is get your tumor marker and refer them to surgery. We don't do biopsies of the ovary. Notice how that was not part of the equation here. And primary treatment is surgical reduction and then chemotherapy afterwards. Next case, a 19-year-old man, 2-month history of a testicular mass. Ultrasound is done and reveals a solid mass. You suspect cancer. Which of the following is the most appropriate next step in the diagnostic workup? Tumor markers and transscrotal orchiectomy, tumor markers and MRI of the scrotum, tumor markers and radical inguinal orchiectomy, tumor markers and transscrotal biopsy, or CT scan of the pelvis with contrast. What do you guys think? Okay. All right. So this one's kind of all over the place. So this one, here's the teaching point here. With testicular cancer or suspected testicular cancer, you never do transcrotal anything. You don't do anything transcrotal because of the risk of needle tract seeding with tumor cells. So the correct answer here is radical inguinal orchiectomy. That is the next step when you have a solid mass on ultrasound within the testicle. Just like with ovarian cancers, with testicular cancer, if you suspect it, take it out. Don't do biopsies. Needle biopsy is never the answer here. So the correct answer is check your tumor markers, refer to urology, and have them do a radical inguinal orchiectomy so there is no risk of tumor tract seeding. So this is a highly curable cancer. Most men do very well, thankfully. These are mostly germ cell tumors. About 60% are non-seminomas, 40% are seminomas. If you have a testicular mass in an older male, think lymphoma, though. The primary risk factor is cryptotorchism or undescended testicle. If you get that in the history, that might further alert you. Be familiar with these tumor markers. They're very useful in initial staging and also in monitoring response to therapy and for relapse. And the basic sort of point to keep in mind here is that with non-seminomas, you can have elevation of all your markers. But with seminomas, you can never have an alpha-fetoprotein elevation because it's a pure seminoma, and alpha-fetoprotein is made by yolk sac tumor, which is only present in non-seminomas. So you can never have AFP elevated in seminomas. And so they've even gone so far as to write questions where they give you a case, a testicular mass, radical inguinal orchiectomy, and the pathology reports seminoma. But the AFP marker is 600. What should you do? And the correct answer is you treat it as a non-seminoma. You don't believe the path report because something was missed there, because it just cannot happen. So don't get tripped up on that. AFP is never produced by seminoma. The most common presentation here is a painless testicular mass. If you have that patient in your office, the next step is always scrotal ultrasound to check if it's solid. If the mass is solid, your next step is tumor markers and radical inguinal orchiectomy. That's your algorithm, that's your workup. You don't biopsy anything, you don't transcrotal anything. Once you've done your surgery, then you can determine staging and role of adjuvant treatment, including chemotherapy or radiation. That's, again, less critical for you guys to know the details. Happy to talk offline if anybody has questions about that. And again, even those with poor risk disease, half of them are probably cured living out to 5 years. So generally speaking, this has a better prognosis than some of the other cancers. Be familiar, and anytime you have a cancer that has a lot of survivors long-term, be familiar with late complications of treatment. Infertility kind of makes sense here. The one that I would want you to be aware of is secondary cancers like leukemias and GI cancers. So these young testicular survivors are at risk for other cancers, and that could be related to some of the treatments that they've received, including chemotherapy. Prostate cancer. Very common. We talked about most common cause of cancer in men. The histology here is adenocarcinoma, 95% of the time. Know the risk factors, and the big ones here are increasing age, race. African Americans have a higher risk and are now being advocated to be screened earlier. And family history is important with prostate cancer. And why? Because there is a genetic component. We're learning more about that and how that's part of the BRCA now. And so a lot of times we're now looking at families with prostate cancer and testing for BRCA mutations. Be aware of this drug finasteride for potential prevention of prostate cancer. There's not a lot of modalities out there that prevent cancer, so there's always interest when we have one. So finasteride is a 5-alpha reductase inhibitor, and studies showed that it did decrease a man's risk of getting prostate cancer, but there was no survival benefit, and even though the men who got this drug had less cancer, the ones who did get cancer, they were worse. They were more aggressive cancers. Therefore, this is not being used widely. It's not FDA approved, but it is an option. And if a question comes up, you won't miss it if you just know that this exists. Screening for prostate cancer, the digital rectal exam and PSA. Recall that normal PSA levels do increase with age. PSA and prostate cancer screening has also been fairly controversial. Lots of different studies, both here and in Europe. Some show benefits, some it's more questionable. A lot of people are concerned about over-treating prostate cancers, and there are some conflicting results. More recently, everybody's kind of coming together, and the general consensus is sort of a soft statement that you can see here, which is shared decision making. So you should have a discussion with your patient about pros and cons of prostate screening. And if you decide to do it, average risk start at age 50. If they're high risk because of family history or African American race, start at age 40 to 45. And what you should be doing is a PSA every 1 to 2 years, plus minus DR, digital rectal exam. Prostate cancer, once it's diagnosed, now is primarily just like with breast cancer in asymptomatic individuals by screening. Before we screened everybody, these men would come in with urinary obstructive symptoms, back pain from metastatic disease, and so forth. So how do we work up a man with an abnormal screen? So a 68-year-old man is seen for nocturia and hesitancy upon urinating. He's had these symptoms for years, but they've worsened recently. A year ago, he had an exam consistent with BPH, and his PSA was 3.5. Now, 1 year later, his PSA has increased to 10. His exam is unchanged. What should you do next? Watch him closely and check a PSA in 3 months, transrectal ultrasound with multiple biopsies, repeat rectal exam and PSA, bone scan, or PET CT scan. What do you guys think? Excellent. So 4/5 of you correctly recognize the workup of an abnormal PSA screen, a transrectal ultrasound with multiple biopsies. That is going to be your next step, regardless of whether it's from an elevated PSA or from an abnormal digital rectal exam, transrectal ultrasound with biopsy. Okay, so we're kind of putting all these in our mind and thinking about them, comparing and contrasting. So a woman, an older woman comes in with an adnexal ovarian mass. You never biopsy it. You go right to surgery after you check your markers. A young man comes in with a solid testicular mass. You never biopsy it. You get your markers and do a radical inguinal orchiectomy. With prostate cancer, a man comes in, PSA is going up. You do biopsy it, and it's a transrectal ultrasound with biopsy. Initial step in working up the different cancers, it'll just be very comfortable in your mind if you kind of review them as you go through. Once you've diagnosed the cancer, you do a staging workup, and there's different factors we look at, a pathologic scoring system called the Gleason score, imaging of the bones, abdomen, and pelvis. Be aware of the different treatment options. If the prostate cancer is localized, we can do surgery, we can do radiation, or we can watch them closely if it's a low-risk cancer. If the prostate cancer is more advanced, we can use androgen deprivation therapy, block testosterone that feeds the cancer. And so this is with our LH-RH analogs, leuprolide, for example. And there are multiple toxicities of this androgen deprivation therapy that you can see here. And then eventually men with advanced prostate cancer will become hormone refractory. And that's when we look at alternate endocrine therapies, chemotherapy, and sometimes even immunotherapy. Bladder cancer, I won't spend too much time on. I want you to know that the histology here is transitional cell in 90% of the cases in the US. Risk factors include smoking, schistosomiasis for squamous cell cancers, particularly in other parts of the world, and certain medications. These patients will most commonly present with painless gross hematuria. You diagnose by cystoscopy with bladder biopsy. And the whole key with bladder cancer is looking for whether there's muscle invasion of the muscle of the bladder. If they're superficial and they have not invaded the muscle of the bladder, treatment is usually through transurethral resection or scraping and then injecting medications into the bladder, intravesical treatments. However, if the cancer has invaded the muscle, then there's higher risk for metastasis, and then they actually need to have the bladder out. Radical cystectomy, often with or preceded by chemotherapy. And then for metastatic disease, we use chemo, and we also use immunotherapy with some of the new checkpoint inhibitors that I'll go over in just a few minutes. So they've been come into strong favor in advanced bladder cancer. Renal cell cancer, histology here is going to be clear cell. So again, we mentioned these histologies for a reason. I think it's just an easy question you don't want to get tripped up on. So remember, prostate's adenocarcinoma, bladder's transitional cell, renal cell is clear cell is the most common. No screening for kidney cancer unless you have a very high risk, usually genetic syndromes or a dialysis patient. And these patients will present typically also with hematuria and flank pain. And they're prone to getting some unusual paraneoplastic syndromes, including this one called Stauffer syndrome, where they have hepatic dysfunction even without having liver metastases. You diagnose with abdominal imaging. This is another cancer where if you get an MRI of the abdomen, you've got an enhancing solid renal mass, go straight to surgery. We don't biopsy kidney masses, so that will never be the correct answer when you have a solid and suspicious renal mass. You go straight to surgery. That surgery can be partial or radical nephrectomy. There are also some non-surgical treatments that can be used. And then I've listed some of the medical therapies that are used for more advanced disease, including, again, immunotherapy drugs and tyrosine kinase inhibitors. But again, focus is on initial diagnosis and workup. So our next question is a 67-year-old man with a strong smoking history. He's dragged in by his wife, who says that he's withered away to nothing and has been acting very confused. He says he's fine, but he keeps calling you by his grandchild's name, and you really can't get much out of him. He has a history of hypertension. He had prostatectomy 5 years ago for a stage 1 prostate cancer. He's lost 30 pounds of weight in the last 6 months. On exam, he's got some scattered crackles in the chest. He's got some hypercalcemia. The calcium's 11.5. You get an X-ray of the chest, and you see a central hilar lung mass with an area of cavitation. Based on your findings, which of the following types of lung cancer does this man most likely have? Small cell, adeno, squamous, bronchoalveolar, or large cell? What do you guys think? Okay, pretty good. So half of you correctly recognize squamous cell. And really, the take-home point here, which I'll cover with you in a moment, but I might as well focus on the question. How would you know that this is squamous cell? It really has to do with two factors. One is the hypercalcemia. So hypercalcemia, if you see that in a lung cancer patient, you think of squamous cell. And the other is the cavitation in the lung mass. So squame, calcium, cavitation, they all kind of sound the same. Think squamous cell if you're given cavitary mass or hypercalcemia. That's how you would be expected to know that. So with lung cancer, what you should know here is that we now do low-dose CT screening for lung cancer. All right, this is new in the last 3 to 4 years. It's now recommended annually, low-dose CT of the chest for women or men who meet the following criteria, and that is at least 30-pack years, and they have to be active or recent smoker, and they must be between age 55 and 80. If they meet all three of those criteria, annual low-dose CT of the chest, and you stop screening when their quit date is more than 15 years in the rearview mirror, or they're 81, or they develop a health problem that would make them not a candidate for surgery. So 20% reduction in mortality was shown in major lung cancer screening trials with low-dose CT. There are 4 major categories of lung cancer. You have squamous cell and small cell, which tend to be central, and then you have adenocarcinoma and large cell, which tend to be peripheral. And for whatever reason, it's a favorite topic of question writers to kind of look at little features that would make you pick one versus the other. So we'll touch on them. We talked about squamous. These are cavitary, like you can see here with a cavitary right lung mass. And hypercalcemia is the one paraneoplastic syndrome that you usually see here. Adenocarcinomas, they tend to be a little more central, and sometimes they can be in the superior or apices of the lung, which is like the superior sulcus or pancreas tumor here. And if you have a tumor up here, it can impinge on the brachial plexus and lead to the classic Horner syndrome with ptosis, meiosis, and anhidrosis. So if they're giving you a lung mass and something that looks like Horner syndrome, you want to think about a superior sulcus adenocarcinoma. Bronchoalveolar carcinoma, which is a subtype of adenocarcinoma. It's also called adenocarcinoma in situ. This may show up in a patient who maybe wasn't as much of a smoker, sometimes in younger women, and they often will have subtle infiltrate type picture in the lung rather than a definitive mass. Sometimes these people undergo treatment for pneumonias and it doesn't get better, and then they biopsy it and it's lung cancer. So it's more subtle. And so recognize this in a patient who maybe is younger and who is not a smoker. And then small cell, this is the really aggressive subtype, high risk of metastases, and high risk of associated paraneoplastic syndromes. Not the hypercalcemia, because that was squamous, but basically everything else. So SIADH, Lambert-Eaton, and so on and so forth. And then this is just some basic principles of management. Early stage lung cancer, if it's non-small cell, we do surgery. If it's small cell, we do chemo radiation. And then we do chemo alone for more advanced stages of both diseases. This just summarizes some of these pearls that we've already talked about, but it's for your reference. Colon cancer, you're going to get in great detail a discussion in your GI section. I just have a couple of take-home points here, including assessing patient risk regarding screening and a knowledge of the different testing options. But again, you're going to hear this in your GI section. If you have diagnosed a colon cancer, you should get a CEA marker, which is a tumor marker for colon cancer. And then you stage the patient. If they have early stage disease, surgery is the first treatment. And then if they have lymph node involvement, you give adjuvant chemotherapy. If the cancer is arising from within the rectum, then we also incorporate radiation. Again, just very basic sort of overview type principles. Head and neck cancer. Know that here are the risk factors: heavy smoking, heavy drinking, but also HPV. Those same bad subtypes, 16 and 18, have been implicated in increasing epidemic of oropharyngeal cancers of the head and neck. The histology is almost always squamous cell when it comes to head and neck cancers. The presentation depends on where in the head and neck the cancer is, but you can see a variety of symptoms that can show up, including vocal hoarseness if it's a laryngeal cancer. You diagnose with scopes, laryngoscopy, bronchoscopy, and then imaging, and ultimately a tissue biopsy. A common scenario that I've seen is they give you a patient who presents with a cervical lymph node, and maybe they have a little bit of hoarseness, or maybe they have a little bit of tinnitus. They ask you, what do you do next? You put a needle in that lymph node. And if you diagnose there's squamous cell carcinoma in that lymph node, then you proceed with imaging of the head and neck and pan endoscopy. So if they give you a cervical lymph node, and you're suspecting head and neck cancer, you do a FNA biopsy of that first. Management here, the take-home point I would say is that there's a growing trend towards organ preservation. And so in the old days, if there was a laryngeal cancer, they would do a total laryngectomy and the patient would have no voice, no ability to talk or eat. Now we're trying to use radiation and chemotherapy to preserve laryngeal function. And so that's been increasing, and these patients are doing just as well. And for metastatic disease, again, you see that immunotherapy, it's kind of gotten into almost all types of cancers now. With head and neck cancer, it is a field defect, and that means they're at risk for other cancers in the field, like lung cancer and esophageal cancer. And if you think about it, it makes sense. These people are heavy smokers, heavy drinkers, so there are other cancers associated with those risks as well. We've included just a few of the more common carcinogens here. We have an audience response question that's going to take us into our sort of last section of oncology, which deals with complications of cancer and cancer therapy. And that is a 62-year-old woman being treated for metastatic breast cancer. She's confused and has a calcium of 12.5 and an albumin of 2.5. What should you do initially to manage her hypercalcemia? Hydration with normal saline followed by zoledronic acid alone. Fluid restriction followed by zoledronic acid, hydration with hydrochlorothiazide and then zoledronic acid, or hydration with 1/4 normal saline and furosemide and then zoledronic acid. What do you guys think? Yeah, that's great. So you guys got this. If you're going to get a single question about paraneoplastic syndromes, I feel like it's going to be hypercalcemia, and so you should know how to manage it. And so normal saline hydration, and then you follow it with a bisphosphonate. That's exactly right. You can see a sampling here of some of the paraneoplastic syndromes, many of which we've mentioned in some form or the other. The hypercalcemia is the most common one. You can see it in a wide variety of cancers. We talked about squamous cell cancer of the lung. We talked about seeing it in myeloma as well. And there's a few different mechanisms by which it can happen. It can be bone mets directly increasing osteolytic activity to leak calcium into the circulation, but it also can be ectopic production of a hormone, this PTH-related peptide. And then in certain lymphomatous diseases or sarcoid type, you can see vitamin D calcitriol overproduction. The symptoms we're familiar with: fatigue, constipation, altered mental status. EKG changes, renal dysfunction, because these patients become profoundly volume depleted. Most important initial step is IV fluid hydration. Don't forget that. Diuretics, only once in a while, only if they're becoming volume overloaded, but the mainstay is IV fluid hydration, and then the osteoclast inhibitor. Zoledronic acid is preferred. Denosumab is a newer drug. It's a rank L inhibitor. This is a different way of inhibiting osteoclast function, and this can be used in refractory cases. And then treating the underlying cancer. Anytime we're talking about bisphosphonates, be aware of osteonecrosis of the jaw. This is the new bad complication that we're seeing. It's fortunately rare, 1% or less, but it is devastating when it does happen. And so all patients in the non-urgent setting being treated with bisphosphonates should undergo routine dental evaluations and clearance because of this problem that can develop with bone healing. So this is a summary again: volume expansion with normal saline, zoledronic acid. Calcitonin can be used if you've got severe hypercalcemia and you need a rapid response. But remember that with calcitonin, you can get tachyphylaxis. So after 2 or 3 days, it stops working. So it's just a short-term stopgap maneuver. Lambert-Eaton syndrome is one of the ones that is associated with small cell, and basically this is a variant of myasthenia gravis. So these patients will present with proximal muscle weakness, and it's autoimmune related to antibodies that impair the release of acetylcholine at the neuromuscular junction. And so there are specific diagnostic tests that can be done here. This condition differs from myasthenia in the sense that with repetitive muscle stimulation, strength actually improves, paradoxically, and the EMG is not affected by the addition of edrophonium. The edrophonium test is not really done in practice anymore, but it still shows up in test questions. And unlike in myasthenia, edrophonium does not improve muscle function here. Treatment is by treating the underlying cancer, and then there are some medications that can increase acetylcholine at the postsynaptic membrane. So Lambert-Eaton, think about a patient with small cell lung cancer, and now they have trouble getting up out of their chair, proximal muscle weakness. You want to think about Lambert-Eaton syndrome in that kind of scenario. There's a listing of some of the direct tumor effects that we can see here, most of which are pretty self-explanatory, but I'll just kind of quickly hit on some of the high points. SVC syndrome, we usually see this with cancers that are in the neighborhood, right? So lung cancer, lymphoma, mediastinal germ cell tumors, compressing the SVC, leading to facial and neck swelling, dyspnea, hoarseness from laryngeal edema, and mental status changes from increased intracranial pressure. This is what it may be hard for you guys to see in the back, but dilated collateral chest wall veins because of SVC syndrome. And plethora of the face, although not shown here, but you can see some neck swelling. You would diagnose by CT imaging of the chest. If you have a patient who presents with SVC syndrome and you don't yet have a cancer diagnosis, you have to get some sort of a tissue diagnosis before you treat them. And as far as what you treat them with, it kind of depends on what type of cancer they have. If it's something that's very chemosensitive, and this is going to be a theme you're going to see with a lot of these cord compression, brain mets, if the tumor is chemosensitive, go with chemo first, such as small cell lung cancer, lymphoma, germ cell cancers. If it's not as chemosensitive, like melanoma or non-small cell lung, then radiation is your preferred treatment for SVC syndrome. But be able to recognize that in the common cancers that would cause it. Bone metastases, this is one of the most common complications that we see in our patient population. The most common cancers that do it are listed here, including prostate, breast, lung, and kidney. And these patients can present with pain, pathologic fractures, and they can be in virtually any bone, but those are the common ones, including the spinal column. You diagnose by either bone scan or a metastatic bone survey, but remember that if you have a purely lytic lesion, it will not show up on a bone scan. So you need a bone survey or a plain film x-ray to see lytic lesions. Only blastic lesions show up on bone scans. Treatment for bone metastases includes radiation to help with pain control. In selected cases, you can do surgery, such as if there's a met in the proximal femur that's occupying a lot of the cortex, and you're worried that if they bear weight, they're going to shatter their hip. You'll ask our ortho colleagues to put in a prophylactic rod. And importantly, we use these osteoclast inhibitors like bisphosphonates in a preventive way to reduce the risk of pain and fracture. And so every patient with bone metastases should be treated with one of these bone modifying agents. Our next case is a 50-year-old man with a history of limited stage small cell lung cancer who underwent chemoradiation 6 months ago. He had a complete response. He presents now with bilateral leg weakness for 3 weeks and mid-back pain for 3 days. Yesterday, he soiled his clothes ×1. On exam, he has point tenderness at T10. What is the best approach to diagnosis and next step in management? EMG and neuroconsult, MRI CT brain followed by steroids, restaging scans and consult oncology, or urgent MRI spine followed by steroids and radiation oncology consult. What do you guys think? Yeah, that's fantastic. So you all recognize that this is cord compression, and this is exactly how it presents. If we go back and look here, when you're reading and you see small cell lung cancer and then bilateral leg weakness, at this point you could be thinking, oh, maybe it's Lambert-Eaton also, right? Because you remember that can happen. But then the back pain, the fecal incontinence, the point tenderness at T10, that talks you right out of that quickly. But just as a thought exercise to tie things together, that's how you can approach a question like this. But that's excellent. So you guys recognize cord compression. This is an oncologic emergency, and that's because the longer you wait to diagnose and treat it, the less likely they are going to recover any neurologic functioning. Any patient with cancer and back pain, you must rule this out. And so the patient can present just like in our case, loss of bowel and bladder control, point tenderness in the spine, back pain, and then sensory and motor changes. MRI is the gold standard. You must image the entire spine because they often have multi-level involvement. So you don't just image where they have their point tenderness, you image the entire spine. And you need a tissue diagnosis, of course, to decide the best treatment. They don't tend to recover neurologic function, so if they're already paraplegic, by the time you diagnose them, then they're unlikely to walk again. So that's why it's an oncologic emergency. Treatment kind of depends on the overall situation for the patient and their cancer. You give steroids to reduce the edema, and in most cases, you'll use radiation. Occasionally, you can do surgery, and that's when either you have an unstable spine or progressive neurologic deficits that are getting worse, or if you don't have a tissue diagnosis, this is the first presentation, or for some reason the patient can't get radiation. Brain metastases, it's a lot of the same offenders. Most of the cancers that go to the bone and go to the spine also go to the brain, as you can see here. The symptoms are kind of, they make sense. Headache, seizures, nausea. MRI, again, is the best test of choice. And what I want you to recall here, because this is fair game, is if you diagnose brain mets, how do you manage it? Again, you give steroids to reduce the edema, and then what you do next depends on how many tumors are they and how's the rest of the body doing as far as the cancer. If you only have got one tumor in the brain, one met, and the rest of your cancer is reasonably well controlled, resect it. If you have a few mets, but otherwise things are pretty good, you do stereotactic radiosurgery. And so that's if there's 3 or less lesions and they're all less than 3 centimeters, stereotactic radiosurgery is your answer. And if you've got more tumors than that, or if they're bigger than 3 centimeters, then whole brain radiation is going to be your treatment of choice. So one met, cut it out. 2 or 3 mets, but under 3 centimeters, stereotactic radiation, and give everybody steroids to reduce the edema. With effusions, we have pleural and pericardial effusions. It's lung and breast cancer that tend to be the most common, and you diagnose this by pleural fluid cytology. You'll hear more about this in pulmonary. The main take-home point I want you to know here is that people with cancer tend to get recurrent pleural effusions, and so you can manage this with either a pleurodesis, where you seal the lining of the pleura shut, or a tunneled Pleurex catheter for home drainage of recurrent pleural effusions. Similarly, with pericardial effusions, these patients can sometimes present with expanding pericardial fluid and even tamponade. Think about lung and breast cancers that are in the same vicinity. And the treatment here often involves immediate pericardiocentesis and then placement of a pericardial window by the CT surgeons to prevent the recurrence of pericardial effusions. In closing, we have just a couple minutes left. I wanted to hit on a couple of key sort of points on chemotherapy and targeted therapy and immunotherapy drugs. So these are the different kinds of cancer treatment that we have available now. And this slide, I would say, is a very important one because these are the favorite side effects that people like to ask about. And so you just shouldn't miss any of these. They'll show up in some form or the other. They'll give you a long case history, and they'll tell you what they were treated with. And so they'll say that this patient had lymphoma, he had this, and vincristine and this, and then now he's got sensory neuropathy, and they'll ask you what drug is most responsible for it, and you're going to be expected to know that's vincristine. Vincristine causes neurotoxicity. Bleomycin causes pulmonary fibrosis. That's the drug we use in Hodgkin's lymphoma, as you may recall. The doxorubicin and trastuzumab, which is the HER2 blocker, can cause cardiomyopathy. Cisplatin is kidneys and ototoxicity, the hearing. The EGFR inhibitors like cetuximab are known for causing a bad skin rash. And then rituximab and a lot of the monoclonal antibodies can cause infusion reactions. I put a slide in here on immunotherapy. I think going forward, depending on how soon you're going to be taking your boards, we're going to be seeing an increasing number of questions related to immunotherapy because this is a game changer and it's the next big thing. Basically, these drugs work by modulating the immune system and releasing the brake on the cancer cells. So it essentially helps the immune system attack the cancer cells. And so you see a longer lasting response and less side effects. It's approved across a number of different cancers. There is a rare risk of serious autoimmune toxicities from these, such as colitis, hepatitis, endocrinopathies. They have on occasion been fatal, and so it's important to be able to recognize these, and the treatment is high-dose steroids for these conditions. And here I have some examples of molecularly targeted therapies. As you can see, like imatinib for CML we talked about, trastuzumab for breast cancer, rituximab for lymphoma. Where they're engineered, they're not chemo, but these drugs are engineered to hit a certain target or actionable mutation. Tumor lysis syndrome, I mentioned this earlier when I spoke about Burkitt's lymphoma, right? That really rapidly growing non-Hodgkin's lymphoma. You want to think about tumor lysis syndrome when you have rapidly growing tumors or those that are very, very sensitive to chemotherapy because you're going to get a rapid breakdown of cellular products that are going to cause metabolic derangements and potentially renal failure. And so this question highlights this nicely. A 24-year-old male, HIV positive, has Burkitt's lymphoma. He's admitted for chemotherapy. And on day 2 of treatment, you see that a lot of stuff is going wrong. His potassium went up to 6.4. His uric acid went up to 12 from 7. His creatinine went from 1.1 to 1.9. And his calcium went from 8.9 down to 7.1. So this is classic tumor lysis syndrome, the classic kind of scenario where you're going to see it. Early treatment with which of the following might have prevented this condition? IV calcium, furosemide, rasburicase, sodium bicarb, or steroids? What do you guys think? Okay, that's pretty good. So 61% of you correctly recognize rasburicase. And so rasburicase is a relatively newer drug, and so let's just talk about when we think about that and what we do with that. So tumor lysis syndrome, we've already talked about what it is. Let's focus more on how we can prevent and treat it. You hydrate everybody, and then you've got a couple of drug options. So allopurinol is the one that we all know about, and it prevents formation of new uric acid. It's a xanthine oxidase inhibitor. If somebody's sort of moderate risk, that's what we use. Rasburicase is the new kid on the block, and what that does is this is an IV agent, and this actually breaks down existing uric acid. So it's far more potent, and we use this as our big gun for patients that are high risk for tumor lysis syndrome. So rasburicase should be used for all patients at high risk for tumor lysis syndrome, and it breaks down existing uric acid levels. That's your teaching point from that case. Febrile neutropenia, I didn't say too much on this because you're going to get it in your infectious disease section, but this is a very important complication. The definition you can see here, and basically this is another oncologic emergency. These patients can become septic very fast. You pan-culture them and then broad-spectrum IV antibiotics. Sometimes we use growth factor support if they are severely neutropenic. And on the last couple of slides, I've just added a few pearls, which is really just repeating a lot of what I've already kind of gone through, but it's a nice reference to kind of summarize, knowing the screening guidelines, risk factors, some of these cancer complications, know everything about breast cancer, and if you have to just know a handful of chemo drug side effects, know the ones on that slide. So with that, I will wrap up, and I thank you guys for your attention.